This is Patricia Dykes. Welcome everyone to the Fall Tips Collaborative Monthly Training Webinar. My name is Patricia Dykes. I'm the Program Director for Research in the Center for Patient Safety Research and Practice at Brigham and Women's Hospital. I'm also Associate Professor at Harvard Medical School. So each month our Fall Tips Collaborative offers a one-hour training webinar to provide information about the Fall Tips program, the tools that we offer, and we provide training on proper implementation and use of the Fall Tips program. So welcome to our webinar. So just to give you a little overview, we'll first be talking briefly about the extent of the problem of patient falls, and then we'll discuss the components of an evidence-based fall prevention program using Fall Tips as our model, and then we'll discuss the rollout of Fall Tips. So I think all of you on the call are familiar with the problem of patient falls. Falls are a leading cause of death and disability. About a third of older people fall each year. When people are hospitalized, it increases their risk for falls. About 3% of hospitalized patients fall, and about a third of those who fall have some type of injury from that fall. Falls and injurious falls are used as national metrics for nursing care quality. So as nurses, we consider falls nursing sensitive, and they are a reflection of the quality of the hospital care that our patients receive. So our team has been conducting fall prevention research for over a decade. Our original Fall Tips study was conducted from 2007 to 2009. And so when I talk about the Fall Tips program, I like to bring people back to 2007 and talk about what was available in terms of fall prevention research and evidence at that time. So in 2007, before we had done Fall Tips, the risk factors were well established. There are many fall risk assessment tools available in the literature with various degrees of validation. So we had a lot of good information about the factors that placed patients at risk for falls. We also had some standardized measures of falls and fall-related injuries, so the NDN-QI metrics, those were available back in 2007. What we didn't have were evidence-based interventions. So, we did have paper-based fall prevention guidelines. So these were guidelines that were, consensus-based. So experts getting together and agreeing that multifaceted, tailored interventions should be effective to prevent falls, but there was no research evidence supporting that. And so what our team set out to do when we were funded by the Robert Wood Johnson Foundation with the Fall Tips study was to kind of go back to the drawing board and look at, why after 30 years of research did we not know definitively what interventions were effective to prevent falls. So we did a mixed method study, including both a qualitative phase, where we went back and talked to nurses and other professional and paraprofessional providers in the hospital. We also talked to patients who had fallen. And we're really curious about, from their perceptions, why it was that patients were still falling in the hospital, and what did they think was both effective and feasible in hospital settings. And so from that qualitative work, we developed a Fall Tips toolkit, and then we conducted a cluster randomized control trial to test its effectiveness. And so the results from the qualitative phase, here we found that falls are really a communication problem, that nurses routinely conduct fall risk assessments. They do this when patients are admitted and every shift. What is variable is the communication related to the results of that assessment and the care plan that the nurse develops. So what we found was that the nurses who do the assessment, obviously they know which risk factors their patients have, but they don't always use those risk factors to tailor a plan for each patient. They also don't always communicate the results of the risk assessment and the tailored plan to the rest of the team. So we found that there was some inconsistent communication across team members, and that this could be a barrier to fall prevention, collaboration, and teamwork. We learned that the non-nursing team members didn't view the fall risk assessment plan and plan in the medical record consistently. So we heard from physicians in physical therapy and occupational therapy that they were quite surprised that nurses were doing fall risk assessments so frequently, and they wanted to know where they could get that information. We also learned that inadequate or incomplete or incorrect information at the bedside was a barrier to fall prevention. So, for example, in all of the hospitals where we did this work, we found that high risk for fall signs were used. We also learned that those were not necessarily useful because on medical units or neuro units, all patients are high risk for falls. And so this became noise in the environment. In order to act on a patient's risk status, you had to know why they were at risk and what interventions were recommended. So, we also learned that all stakeholders, including patients and family, needed to work together to prevent falls. And so from that qualitative work, we put together a set of fall prevention toolkit requirements. So our first was that, we had to leverage existing workflows, that nurses and all of the staff in the hospital told us that they're really very busy, that we needed to look at what they were doing already and try to leverage those workflows, help them to do that more efficiently. And the workflows that we saw in every hospital were that nurses were doing fall risk assessment quite frequently, in most places every shift. And the second was the use of these high risk for fall signs. Another requirement was teamwork, that we needed to leverage the whole team because nurses have many complex patients that they're caring for in acute care hospitals, that they can be in a room and caught up for 20 minutes, and they're expecting their team to be able to answer call lights and help their patients. So that means that we need to communicate. We need good communication at the bedside to ensure that not only that anyone who answers a call light is aware of each patient's individual risk factors, but also the tailored interventions or the personal interventions that are needed for each patient to prevent them from falling. And then finally, that we needed to our tool needed to support surveillance, that as we move from four-bedded rooms, two-bedded rooms to single rooms, surveillance has become more difficult. So when I first started practicing in the late 80s, there were four-bedded rooms on my orthopedic unit. And so when we'd be, if Mr. Jones started to get up, Mr. Smith would put the call light on and let me know. So we can't always depend on other patients to tell us when a patient needs help. We need to be able, as we walk down the hall and we're looking in the room or providing rounds, we need to be able to see at a glance. If a patient's getting up and they should be getting up, we want to encourage that. If they need help, we need to help them quickly, and we need to know how to help them and to do that safely. And so this is the original Fall Tips Toolkit. It was in our electronic medical record. On the left-hand side is the Morris Fall Scale, which is the fall risk assessment. And then on the right side are the interventions that we learned in our focus groups from the nurses and the other professional and paraprofessional providers that were thought to be both effective and feasible in the busy hospital setting. And so the way this worked, that as the nurse filled out the fall risk assessment on the left, in the background, the decision support would automatically select the interventions that were most likely to prevent a fall. And then once the nurse completed the risk assessment, they could further tailor based on their knowledge of the patient, but it produced an evidence-based plan for every patient. And so once they filed the assessment, there were three different outputs. So one is a bed poster. So we talked about the bed posters that were in place before Fall Tips, which were generic and had the limitation that, it told you the patient was at risk, but it didn't tell you, how you could help that patient. So if you look at the Fall Tips poster, they had anywhere from 0 to 6 icons. 0 icons meant that, the patient didn't have, that they were assessed, but they didn't have any risk factors. For this patient, Jane Doe, if I answer Jane's call light, I could see that she has a history of falls, which means she's fallen before. She's more likely to fall again and under similar circumstances. So I would, ask her about that fall. If Jane tells me that she needs to go to the bathroom, I can see that she's one person assist, so I can get her up by myself. If there's a walker and a cane on the windowsill, I know that the walker belongs to her, that she should be walking with her walker. And if I walk her to the bathroom, I can see that she can't be left alone because she has a bed and chair alarm icon. So that means either she's confused or she doesn't reliably call for help. And so on this poster is the core set of information that nurses or bedside caregivers need to provide care to unfamiliar patients that is safe and effective. The other printout that came out was a patient education sheet. So this is the same information that's on the poster, but translated to a patient level of health literacy. It's used as a teaching tool with the patient. And so what we learned in our research from patients and families, when patients are in the hospital, they're not feeling well, they don't have the capacity to read a lot of information. And so what they asked for was, just what was pertinent to them. They don't like generic information, but what are their risk factors and what do they need to do to prevent fall while they're in the hospital? And that's what's on this form. And then the third, at that time, we had a paper record, a paper plan of care. And so this is the plan of care page that shows the fall risk. It's the same risk factors and interventions that are available on the other tools, and this was in the paper chart. And so we did a 6-month study. We had over 10,000 patients in our study. We did see that there were fewer falls in the intervention units than the control units. We found that fall tips was most effective with patients 65 and older. We did not see any difference in fall-related injuries, but we were not powered for that. So our statistician had told us that, to detect a change with patient falls, we needed 10,000 patients. To detect a change in patient falls with injury, we needed about 80,000 patients. So that would have been a several-year study. But what we said in our JAMA paper was that, if you prevent a fall, you potentially prevent an injury. And so we believe that over time, as long as we used fall tips, that we would prevent injuries as well. And so we had several lessons learned in this fall tip study. So coming out, we said, all right, so fall prevention in hospitals is a 3-step process. We need to conduct fall risk assessment, and we have to use, a prospectively validated tool. We were using the Morse Fall Scale. And then we need to use the results of that assessment to develop a plan of care that's tailored to patient-specific areas of risk. And then we need to implement the plan consistently. Now, in order to implement the plan consistently, we have to make sure that patients and family are engaged. So when we finished the first fall tip study, we also did a case control study to look at the patients who were on the fall tips intervention unit and they still fell. And we found that the most common factor was that the patient didn't follow their plan. And when we did interviews with patients, what they told us was that their nurse did tell them that they were at risk, but they didn't believe it. Many of these patients were younger, they're independent at home, and didn't actually believe that they were at risk in the hospital. They didn't understand the factors that placed them at risk. And so what this taught us is that we have to make the patients part of this 3-step process. So instead of using the typical workflow, which is, the nurse goes in, does their fall risk assessment, develops a plan, and then teaches the patient about it, in order to make sure that the plan is consistently implemented, we should do the risk assessment with the patient so they really understand their risk factors. And then we develop the plan with the patient so that they agree and partner with us to make sure that it's implemented consistently. And so, we said coming out of that study that, strategies and tools to facilitate the 3-step fall prevention process would prevent patients from falling. We did have a couple next steps coming out of, the first set of fall tips work. One was that we had a lot of requests from hospitals all over the country asking, how they could use fall tips at their hospital, that they didn't have an electronic record or they didn't have a sophisticated electronic record. So they wanted to know how they could implement this evidence without the electronic record. We also knew that it was important to try to look at this patient engagement piece. And so we had one goal to develop tools and strategies to engage patients and families more in the 3-step fall prevention process. So we were funded by AHRQ to develop some patient-centered tools, and one of the tools that we developed is this laminated paper fall tips. So here we collaborated with the systems engineers at Northeastern University and also the folks down at Montefiore Medical Center to take the assessment and the intervention from our original fall tips and to translate it onto a paper tool. And so you can see here on the left-hand side of this tool is the Morris Fall Scale, translated into a patient level of health literacy. On the right-hand side are all the same interventions that we used in our original fall tip study. And so the way this tool works is that it's printed 11 by 17. There's one at every bedside of the patient. When the patient's admitted, the nurse takes the tool down, does the fall risk assessment with them, develops the personal plan with them. The color on the sign provides guidance to the nurse to provide clinical decision support to ensure that all patients get an evidence-based plan, and that not just the patients who are, or not just the nurses who are expert in fall prevention. Our partners down at Montefiore Medical Center, 60% of their patients, their first language is Spanish. We also developed the back side of the sign to be Spanish so that they had both languages available. And then we did a 6-month trial looking at the effectiveness both at Brigham and at Montefiore. And what we found was that the adherence with the protocol, so that is the nurses, the sign being updated and the nurses doing the assessment and the plan with the patient, was about 82%. Our fall rates dropped from 3.28 to 2.8, and our injury rate dropped in half in this study. At Montefiore Medical Center, they had very good adherence, about 91%. Their fall rate pre-fall tips was 3.04. Their fall rate post-fall tips was 3.1, which is statistically the same, but they also saw a nice decrease in injury rate from 0.47 to 0.31. And so what this study taught us was that, by engaging the patients and family in all 3 steps of the fall prevention process, it made the fall tips intervention stronger, the dose of the intervention stronger. And we published a paper with this evidence in the Joint Commission Journal on Quality and Safety last August. And so, 10 years after the first fall tip study, we have quite a bit more evidence available to us. So one, we know that patients are a common problem, but they can be prevented using the 3-step fall prevention process, and that's doing the risk assessment with the patient, developing a tailored plan with the patient, and then making sure it's consistently implemented. The electronic health record clinical decision support can link patient-specific risk factors to the interventions that are most likely to prevent a fall in each individual patient. But we also have tools that are available in clinical care that will integrate this 3-step fall prevention process into the workflow, and the laminated poster is another example of such a tool. We also know that engaging patients and family in the 3-step fall prevention process ensures that they'll understand their risk factors and that they can play a role in ensuring that the fall prevention plan is implemented consistently. And this is our team from here at Brigham and Northeastern University and at Montefiore Medical Center that was involved in developing the tool. So now that you've learned about fall tips, we're going to talk a little bit about the components of an evidence-based fall prevention program. And so just to recap, for evidence-based fall prevention, we need universal fall precautions. Now all patients get those. I don't think we need to document separately. We shouldn't have to select them for the care plan. Universal fall precautions are for all patients. And then we have the 3-step fall prevention process, which we just talked about, and we'll go into that in a little more detail. If patients do in fact fall, we should have a post-fall prevention fall management strategy. And then we need implementation strategies. So we know that acute care workflows are complex, so we need to think very carefully when we implement a new program to make sure it's successful. And the strategy includes unit-based champions, having competency, and then continuous quality improvement strategies, and we'll review all of this. First, the types of falls. So, there's preventable falls and non-preventable falls. The good news is that most falls are preventable. And under preventable falls, we have accidental falls. So these are falls that occur these could occur in any patient. They're usually caused by an environmental hazard, and they account for about 14% of falls. We prevent accidental falls by using universal fall precautions. Also preventable are anticipated physiological falls. So these are patients that occur in those who do have risk factors for falling. And this is why we do a fall risk assessment. So, for example, the Morse Fall Scale has 6 items that you can use to predict this type of fall. About 78% of falls are in this category of anticipated physiological falls. Now, we prevent this type of fall by using the fall risk assessment and then creating a tailored plan with the patient to address each of the risk factors that's present. And then the one type of fall that is not preventable are unanticipated physiological falls. So these are also caused by a medical or a physical problem, but it's one that we haven't diagnosed yet, so we don't know about it. So, for example, it can be caused by physiologic changes such as a seizure. So you have a patient who has no history of a seizure disorder. You're walking down the hall with them, post-op day 1, and the patient has a seizure and falls. So you could say, well, you didn't know that patient could have a seizure. There weren't precautions taken. You couldn't have avoided it. This was an unanticipated physiological fall. That accounts for about 8% of falls. These are difficult to prevent, and some of them may not be preventable. So the evidence-based fall prevention strategies we have, again, are universal fall precautions, a 3-step fall prevention process, and then when falls do occur, having a post-fall management strategy. The universal fall precautions are the cornerstone of any hospital fall prevention program. Most hospitals train all staff who interact with patients that these universal fall precautions apply to all patients at all times. So we keep our pathways clear, we wipe up spills immediately, make sure patients have access to their call bell, and we provide non-skid footwear. And so having everybody buy into these and practice universal fall precautions creates a hospital culture that values fall prevention. And next we have the 3-step fall prevention process, which we've talked about relative to the fall tip study, but we're going to view here in a little bit more detail. So first, conducting the fall risk assessment. So with fall risk assessment, this is really important because the fall risk assessment is going to help us identify those patients who are at risk for anticipated physiological falls. It'll provide a baseline measure of the patient's specific areas of risk that we can then use to help our clinical decision making. And then also the results of this assessment will inform the tailored or personalized preventative interventions that we're going to implement. So in terms of the Morse Fall Scale, it does require both a chart review and direct observation of the patient. It should be completed once a shift, typically in acute care hospitals, mostly because patient status can change quickly. The scores may fluctuate from daytime to nighttime. Completion of the Morse Fall Scale requires training. There's some areas of risk that you can't tell just by the way the risk factor is written, what it means, so it does require training and competency assessment, and we'll be going through that competency right now. So here is the Morse Fall Scale. Again, there's 6 areas of risk. We'll go through each one in depth. I think one of the strengths of the Morse Fall Scale is it addresses all of the major predictors of falls in an acute care hospital. So if you look at the work of David Oliver, who has summarized, all of the risk assessment studies out there, and the major predictors of falls fall into these areas of risk. So we'll go through them now. So the first is history of falling. So we know that patients who have fallen before are much more likely to fall again and under similar circumstances. And so the important thing here is that if patients have fallen recently, and this is within the last 3 months, that we need to find out from that patient and the family what were the circumstances around that fall, not just because we want to know that, but because we want to use that information to inform their care plan. So, for example, if the patient tells you, well, last week I got up in the middle of the night and I was walking and I to the bathroom and I got weak and my legs gave out, well, we know that that could happen again in the hospital. So we want to make sure that we put interventions on their care plan, maybe a toileting schedule, assistance to mitigate that risk. So the interventions here, obviously we're going to have safety precautions for all patients, but we want to make sure that whatever the cause of their previous fall, that's communicated and it's present at the bedside, and that's where the Fall Tips poster can help, because we can document it there. The second area of risk is secondary diagnosis, and so if you look at the original writings of Dr. Morse, this does cover, if patients have multiple medical diagnoses, but the reason it was significant in the Morse Fall Scale risk model was that patients who have multiple comorbid diagnoses, they also tend to be on long lists of medications. And so when staff are assessing for, this secondary diagnosis, they need to be thinking about the increased risk for falls that are related to the multiple medical problems, but also the medications that patients tend to be on. So, for example, are there side effects such as dizziness or frequent urination or unsteadiness that the patient has because of their medications, as well as, some of the symptoms from their medical problems. So the interventions here are, you might consider implementing a toileting and a rounding schedule, reviewing their med list. The third area of risk is ambulatory aid. And so here, it's not just what's ordered for the patient, but do they actually use it? And so to assess ambulatory aid, we're supposed to be, making sure the ambulatory aid is available at the bedside, and then observing the patient when they get up. Is their first inclination to grab the ambulatory aid and to use that to walk, or do they grab the bedside table or other furniture, which in the hospital we know has wheels? And so that's why with this particular area of risk, furniture, when we score it, furniture is the third option that puts the patient at the highest risk because of the dangers of using furniture on wheels for ambulation. So the interventions are that if a patient needs an ambulatory aid, we need to make sure that they have one at the bedside. We should be reviewing the dangers of using hospital furniture or any hospital equipment as an ambulatory aid. We should assess their ability to use the ambulatory aid, and if they need assistance with that, we would consult with physical therapy. The fourth area of risk is IV or heparin lock. And so here what we're, thinking about is not just, is a patient attached to an IV, so they need help with the pull, but more, but looking at what is going in through that IV or heparin lock. So, for example, patients who have an IV, they're getting extra fluids. They might have frequency, they might have urgency and have to jump up and go to the bathroom. So these patients might need a toileting schedule. What medications are in that IV, and what kind of side effects might those have? Could it make the patient unsteady? Could it make them dizzy? And reviewing those with the patient. If the patient has a heparin lock, are they getting medication through that heparin lock? And again, what is the medication that goes in there? And what are the side effects? If they're not getting anything, then, I think one of the most common questions we get is, if a patient has a heparin lock, do I still, but they're not getting anything into the heparin lock, do I still score it as yes on the, 20 points? And what we always say is you score what is present as present. So if, on the risk assessment, you would say, yes, the patient has a heparin lock, so you score a 20. But, for each risk assessment, you then have to think about, does the patient need an intervention? And so the clinical judgment here, if the patient's not getting anything in their heparin lock, then we wouldn't select an intervention, but it's still present. So the interventions for the heparin lock and IV: implement the toileting or the rounding schedule, tell the patient to call for help with toileting if they need help getting up, and then reviewing the side effects of any of the IV medications that they're on. And then the fifth area of risk is gait. So here we are looking at, does the patient have a normal gait, and if not, is it weak or is it impaired? So, I think, in terms of the weak gait, these are patients who, when they first get up, they might be stooped over a little, they might shuffle, but once they get going, they can look forward, and their gaze will be on their target, wherever they're headed. However, the patient who has an impaired gait, they have a very difficult time getting up from the chair. If the chair doesn't have arms, typically they wouldn't even be able to get out of the chair. Once they do get up, their head is down. They can't walk, and they're really kind of grabbing for furniture or whatever else is available. So these patients, really need a lot more assistance when they're walking. Usually, when you should assess gait with the ambulatory aid, because very often a person who has an impaired gait without their ambulatory aid, if they're used to walking with a walker, once you give them the walker, then it might just be a weak gait. So making sure that this gait assessment is done with the ambulatory aid. And so the interventions here would be if the patient needs help, providing that to get out of bed, and also considering a physical therapy consult to either get them an ambulatory aid or to work on the gait problem. And then the last area of risk is mental status. To test mental status, we should ask the patient, are you able to go to the bathroom alone, or do you need assistance? And we score normal if the patient response is consistent with what we know to be true, and we score 15 or forgets or overestimates if the patient's response is inconsistent with what their ambulation order is, or it's unrealistic. So, for example, you have a patient who has a gait disturbance, and that they do need assistance with the ambulation. And when you ask them if they're able to go to the bathroom alone or do they need assistance, they say, oh, no, I'm fine. I do this all the time at home. I don't need help. Then that's a patient that we would score as mental status positive. And these are the patients that we would provide a bed alarm or chair alarm. We would provide virtual monitoring, making sure the patient's in a visible location if possible, encouraging their family to be around and to call if the patient needs help. And these are the patients that really do require frequent rounding to make sure that, we're checking in on toileting, and that if they're thinking about getting up, we're there to help them. At Brigham and Women's Hospital, we do assess for not just the risk for falls, but the risk for harm. And so we use the ABCs of harm, which is an IHI mnemonic, and it's age. A is for age, so for patients who are 85 years old, or if they're very frail, that puts them at risk for injury if they fall. B is for bones, so this would be a patient with osteoporosis or risk of fracture. C is for coagulation, so this is patients who are at risk for bleeding, they have low platelet counts, or they're taking anticoagulants. And then S is surgery, so patients who have had recent surgery, lower limb amputation, major abdominal or thoracic surgery. So what we found in our research is that, for risk of injury, it's very important to let patients know. If you do the injury risk assessment and you find that it's positive, communicate that to the patient, that they are at increased risk for injury if they fall, and emphasize the importance of them following their personalized fall prevention plan. What we've learned from patients and family is that if they knew they were at risk for harm, if they fell, that they would be more apt to follow their fall prevention plan. So it is very important to share this with the patient. Okay, so that is, we talked through number one, conducting the fall risk assessment. We also talked about the second step in the three-step fall prevention process, which is completing the tailored fall prevention plan, because we talked about interventions as we were going through the assessment. But just a couple more points about care planning. We want to review the areas of risk that are identified by the Morris Fall Scale for each patient. And again, we want to do this with the patient. We want to select, for every area of risk that's positive, we want to make sure that we have one or more interventions to address that area of risk. And then we want to make sure that we communicate the tailored plan to all the staff who are interacting with the patient. And again, making sure that patients and family member are also involved in that communication. And then the third step of the three-step fall prevention process is consistently implementing the plan. So carrying it out consistently, and patient engagement is really the main factor that can help with this consistency. So with patient engagement, we are engaging patients and family in the three-step fall prevention process to ensure that they understand their risk factors, that they can play a role in making sure that the fall prevention plan is implemented consistently. We conduct the fall risk assessment with the patient, and when we develop the tailored plan together with the patient that's based on any of the risk factors that are identified. And then we have to consistently educate and remind the patient about how to implement the plan. And so having a poster like the Fall Tips poster at the bedside that has both the risk assessment and the results of the risk assessment and the plan to prevent a fall at the bedside, and using that as a cue to remind the patient at least once a day, that can really help with making sure that the patients and the family help you to consistently implement the plan. So on all of the units that have implemented Fall Tips within our collaborative, on the nursing units, they conduct patient engagement audits. So on every unit, there's nurse champions. They submit 5 or more audits a month, and they submit them into REDCap. So we see the data. We have good data showing that when these audit results are strong, that we see the fall rates go down. And so the 3 things that nurse champions are looking for in patient rooms when they do the audit is, first, is the patient's Fall Tips poster updated and hanging at the bedside? So does it have the right patient's name on it? Does it have today's date? The second is, can the patient and family verbalize their fall risk factors? And third, can they verbalize their personalized fall prevention plan? So again, when patients know their risk factors and know their plan, they're much more likely to follow it. Now, once the nurse champions complete the audit, they give feedback to the nurse who's caring for the patient, because there's many reasons why a audit tool might not be updated, or the patient might not know their risk and their plan. And so providing peer feedback, getting the nurse's perspective on what's going on with that patient or what some of the barriers were to updating is really important. And that coming from a peer, so a nurse on the unit versus someone from the outside, is very, very important. Our team has been, has implemented Fall Tips in many hospitals, and we've been doing this for over a decade. We have a whole suite of tools to support the Fall Tips rollout, including a training module. We have monthly training webinars, and this is one of those. We also have a Fall Tips audit guide, and we have one-pagers of information about Fall Tips for nurses, for patient care assistants, and also patient guides. We have an email address, so you can email us at any time, and we have a website where anyone can access all of our tools and join the Fall Tips Collaborative. So here are this is a summary of the Fall Tips implementation protocol. So we talked about earlier how important it is to really think carefully about implementing a new program, that the workflow on acute care hospitals is very complicated and busy, so we need to make sure that we think through the implementation process and work with all of the relevant stakeholders. So, for example, we need to have organizational support. So from the chief nurse, the unit directors, the nurse managers, unit champions, so making sure that there's good support for the program. Making sure that you have the right tools. So if you're using the laminated poster, making sure that those are printed out and available, and that you've thought through how you're going to hang them in the room. Meeting with practice committee and unit nurses, making sure that at the unit level that nurses are involved in the process of implementing and training and are given the option of becoming champions. And then conducting fall risk assessment competency and training. So I went through the training slides for the Morris Fall Scale with all of you today. I hope there was something in there that you learned that you might not have known before, but I tried to point out the areas that do take training that nurses don't know just from looking at the Morris Falls scale how to assess it. One being maybe the history of falls, that you need to not just find out the specifics of that fall, but then you need to use that to update your plan of care and communicate that at the bedside. That the gait assessment, for example, needs to be done when the patient's using their assistive device. Another common misconception is that for patients, we've heard from many nurses that they use bed alarms for any patients who is at high risk for falls. And so what we've learned is that we use bed alarms when patients don't reliably call for help, but not based on their level of risk, which is for number 6, positive, mental status positive. We also have, you have to track progress weekly. So, especially in the beginning, having champions give feedback to staff about, whether their Fall Tips tool is completed, and then over time conducting the audits. And so the audits provides an opportunity for continuous feedback. We have tools to provide charts, for the members of our collaborative that shows how they're doing with the audits and falls with injury relative to the rest of our database. So now we will go to a case study and look at how that might be, how we might use the Fall Tips tool for this patient, John. So John's an 82-year-old man. He's got diabetes. He was admitted to Brigham and Women's Hospital, a medical unit, with chest pain and shortness of breath. On admission, John was found to be alert and oriented. He had an IV and he was placed on a cardiac monitor. During the admission interview, John reported that with his cane, he was independent with walking and transfers. However, the nurse noted that the doctor's order was for walking with cane and assistance only. With further questioning, John reported that he had fallen at home several times over the past year, most recently last month. As the nurse assisted John to the bathroom, she noted that initially he used the bedside table and other furniture as guides, and he needed to be reminded to use his cane. But once he was given his cane, John walked with short, steady steps to the bathroom. And so here we have the laminated paper tool. So again, the workflow around this is that we have one of these at the bedside of every patient. It's in a place where both the patient and the staff can see, because it is a tool for both patients and family and staff. And so completing this with the patient, we know that John has a history of falls. So, we're going to say, that we're going to communicate that, but we're also going to ask John about that fall. And, based on what he tells us about it, we might select additional interventions. In terms of multiple comorbidity, that is, John does have more than one medical diagnosis. He's on multiple medications. So with John, we are considering a bathroom schedule for him. He can walk to the bathroom, and we put him on a toileting schedule every hour. In terms of walking aids, John is supposed to be using his cane. We noticed that, he didn't initially grab for that, but he does need his cane. And he is attached to an IV, and he needs help with that. But we're also considering, again, what's going into that IV. So he's getting fluids. We're putting him on a toileting schedule, and we're going to walk him to the bathroom. And then in terms of John's gait, he seemed to have unsteady walk, so we've ordered one person assist for him. John thinks he's independent, but we know that actually John needs assistance. So for John, we're going to use the bed alarm, and we're going to tell him that, we're going to use the bed alarm to make sure that he remembers to call us, because we don't want him to fall while he's in the hospital. So that is Fall Tips and evidence-based fall prevention, and I'll just give a little recap. We know that most patient falls are preventable. An evidence-based fall prevention program includes the following. So we have to have standard definitions about falls and injuries. We need to have universal fall precautions in all for all patients. We need to have the 3-step fall prevention process, where we're using a valid and reliable fall risk assessment tool to do the risk assessment with the patient. We need to also develop a personalized personalized or tailored fall prevention care plan, and then we need to consistently implement it. If patients do fall, and unfortunately there are always going to be some falls because not all of them are preventable, while most are, we have to have a post-fall management program. And that implementation of fall tips requires a continuous quality improvement and interdisciplinary team-based approach. We have I mentioned throughout the presentation today that we do have a Fall Tips Collaborative. We are currently trying to spread fall tips to make this evidence available to any hospital that would like to use it. The benefits of joining the membership is you get ongoing access to the Fall Tips Toolkit, our training webinars, and the implementation guide. We will provide you with monthly reports related to your hospital's progress with engaging patients and family in the three-step fall prevention process relative to other hospitals that are in our database. And the requirements for membership, there isn't a charge, but we do ask that you submit de-identified data monthly via our REDCap link to a secure database related to engaging patients in the three-step fall prevention process, your falls, and your fall-related injuries. So if any of you are interested in joining, please sign up at our website, which is falltips.org.